Good afternoon. I hope I'm not too loud. I said don't get the mic too close to me because I'm loud to begin with. And I want you to know that I did not pick the bacon out of my potato salad, so I just need to start by announcing that. The topic today is distress versus diagnosis, mood and anxiety symptoms in cancer. It almost sounds like we're going to duke it out a little bit here, but we're really not, so rest assured. Most of us know something about the burden that cancer patients and their families face. For most patients, they hear the diagnosis and they have a multitude of questions. What am I going to do about work? How am I going to talk to my family? How am I going to talk to my kids? One of the most difficult. That is your brain on cancer, working really, really, really hard. Some patients have other questions that are significant as we think about cancer as a chronic disease and look at chronic disease model. For example, a lot of patients want to know what they can do to help themselves. What kind of diet, what kind of exercise is going to help me get better? As we shift in thinking about self-management and self-efficacy, I want you to keep one thing in mind. If you have a patient with distress, with symptoms of anxiety or depression, there's a real risk that they're going to get left behind in that. I wanted to just start by highlighting something that was reported in the papers and in the news more recently. And it was a report done by the Institute for Clinical and Evaluative Sciences and Public Health in Ontario. And it basically was measuring the burden of mental health. The report is actually called Opening Eyes, Opening Minds. And I was interested in this because one of the things they concluded was that the overall burden of mental illness is more than 1.5 times that of cancer. I thought that was quite a concerning statement. How they measured it, and I'm not going to get into the details of this, but they looked at number of cases, how long the disease lasts, how it affects life, and how often it contributes to early death. The reason, though, I wanted to bring it forward today is just to highlight one question for you. What if you've got both? What if you have a new diagnosis of cancer and you're someone that's struggled with anxiety or depression symptoms for years? Or what if you develop these symptoms during the course of your cancer treatment? As the title suggests, we're talking about distress versus diagnosis. And in the context of cancer, most of the time we're thinking about distress on a continuum. So on the one end, you think about mild or expected distress. You've got cancer, you're going to have some distress. In the middle range here, we've got moderate. This is where at the high moderate end, it can actually affect your ability to cope, can affect quality of life, can affect your ability to actually go along with the treatment recommendations. At the far end is severe distress. And this is the diagnosable things. These are the things that Dr. Garcia is going to spend quite a bit of time this morning talking about. The questions, though, that we have are what's normal, what's not, who needs help, what kind of help, who should provide that help, and when. Most of us have heard cancer patients talk about their diagnosis as being an emotional roller coaster. And I know some of you have seen the roller coaster before. You're going to see a lot of it today. This is a great roller coaster, not one that I would want to be on by any means, but it really doesn't, I think, capture the cancer experience because it implies that it's all front-end loaded, that you go up the hill, you're terrified, on the way down, you scream your head off, you breathe, and it's all okay from there on. I think it's really more reflective of this roller coaster, where there's a number of hills of terror along the way, each one representing, I think, a peak of distress or a peak of anxiety or even a peak of depressive symptoms. These, within the context of cancer, I think should be thought of as particular points of vulnerability. So it would be essentially the pre-diagnosis or diagnosis phase. That's a no-brainer. You're going to have high distress there. Just before the start of treatment, you don't know what to expect. Just after treatment, another peak. Another no-brainer. If you are dealing with recurrence, that's obviously a very difficult time. The last one that not as much previously was known about, but it's really been a focus now of cancer care is into survivorship. We know that anxiety and distress peaks at that point in time. It peaks when treatment's done and we're going to discharge patients back to their primary care. Whenever we think about the question of what's normal in the concept of distress, what we're looking for is some kind of adjustment or some evidence of adaptation. This can be described as an ongoing process in which the patient tries to manage emotional distress, solve specific cancer-related problems, and gain mastery or control over cancer-related life events. So normal or successful adjustment can be thought of as involving, for example, things like the ability to manage disruption to one's life. This would be more of a problem-focused. Another one would be learning ways to regulate emotional distress. This would be emotional-focused. And then the third one is more about meaning-focused. And Dr. Garcia just wanted to make a couple of, I was going to try to do it, but I'll let her do it. Just a point about this particular slide.
Yeah. You're going to hear me talk about this because this is actually, at its most sort of concentrated, one of the things we think about when we're trying to figure out who's at risk to have problems with coping with distress, with all the craziness that comes with cancer, who's likely to need someone like me, and who's probably going to have some bumps but then be okay. And it's really about your ability to adapt to rapidly changing problems and stressors. And there's three main ways of coping, and they're all good or bad depending on what kind of problem you have. So problem-focused is great if you can change your circumstances. So, for example, I'm really stressed out because my credit cards are maxed out and I have a whole bunch of things coming up and I don't know how I'm going to make it through Christmas and blah, blah, blah. Okay, that's a problem you can probably address through problem-focused coping. You can make a spreadsheet, cut your spending down, maybe not indulge in a few things. It'll be okay. That's a really good way to solve that kind of problem. Emotion-focused works great when you can't really do anything about it. So something happens that there's nothing that you can try, that you can impose change on. So the classic example here are natural disasters, things that are out of a person's control. And there, the people who do best, who avoid getting into problems, are the ones who can focus on regulating their own emotional reaction and just let everything else kind of happen as it's going to happen. Meaning-focused is in some ways the trickiest thing to do, which is to actually forget about what you can control and what you can't. To some extent, let also go a little bit of your emotion regulation and really focus on what gives my life meaning, what gives meaning to the world around me, and pulling that out of everyday experiences. So there are three different kinds of coping. They all can be really good or really bad, depending on when a person is using it. So you'll hear me talk about rigid coping styles, and what I mean is one person using one way of coping for everything. And most of us are able to move back and forth, and that's what allows us to rise to different occasions. And you can just imagine if you're a cancer patient, how many different things are going to be thrown at you even in the course of the first week of treatment. So being able to change your adaptation style ends up being critical.
So now you know why I wanted her to elaborate a little bit more on that screen. So again, what's normal? We have this idea of phases, and we learned a long time ago with Kubler-Ross that we don't see these as concrete phases per se, but more fluid processes. So initially, the response is really around disbelief. You may see denial. You certainly will see despair, and I'm going to say it's longer than a week. Then you get into dysphoria. You certainly will start to see depressive and/or anxiety symptoms. If it is prolonged, then you're wondering about, is this going to turn into be adjustment disorder? Is this psychiatric disorder? And then finally, there's the whole process of adaptation. So again, these are not concrete phases, but a fluid process. When you're thinking about distress, anxiety, and depression, the reason we're talking about them together, again, is because we use these words, we throw them around, but really there is a big difference between what's a diagnosable anxiety disorder, what's a diagnosable depressive disorder. One of the main things I just wanted to sneak in here as well is that distress in the context of cancer is actually seen now as being the sixth vital sign. So for all the nurses out there, and I know you're there, pain, temperature, pulse, blood pressure, respiratory rate, and distress. And actually, the whole concept of distress in oncology started about, well more than about 10 years ago. But I just wanted to draw one of the major achievements of a Canadian group that really contributed to the literature on the concept of distress in cancer. So this was a major study done in Alberta. They screened over 3,000 patients and actually found that 37.8 found that they had significant distress. So this is within the clinical range. It's actually going to affect their ability to cope, affect their quality of life. The other thing they found is that there was no real difference for anxiety or overall distress for men and women, although they did find higher rates for women in terms of depression. So gender is a factor. They also contributed significantly by identifying disease sites where there are higher levels of distress. So lung, not surprisingly, was the winner. These patients have lots of symptoms. They're almost at the 60%. So there's a huge range there from 26, 27, all the way up to almost 60. So the point is here that the actual disease factors and disease site variables and symptom burden do play an important role in terms of distress and coping.
So really, I think what Marlene, I think, has done really well in those first slides is sort of introduced you to the idea of distress as being something that's quite common in the lives of our patients, right, while they're going through the whole cancer trajectory. And then my part is to try to figure out when things go off the rails a little bit and we move out of normal distress, whatever that is, into something that's actually much more toxic, that might actually really interfere with their care, with their ability to sustain treatment. And in order to talk about that, we first have to talk about factors of adaptation. So this is, all the stuff we were talking about before in terms of how people cope, how people adapt to rapidly changing problems, right? And again, if you think about your average patient, from the day they show up in their doctor's office and get the news, as they move forward on this, it's daily. They're facing new challenges they never had to deal with before, and learning how to do that quickly and effectively is the thing that can help them the most to prevent having something quite catastrophic from a mental health perspective. So the three big things we think about in terms of trying to predict who's going to do that well and not so well are patient factors, disease factors, and environmental factors. I'm going to talk a little bit about what I mean about those. I'll warn you now, I am a wanderer. I will try not to wander too far afield, but I tend to move and talk. So these three groups, patient factors, we've already kind of hit on some of the big ones here. One of the most important things is whether the person, the patient in front of you that you're worried about actually has a personal history of having troubles with a mood disorder or an anxiety disorder, or in their family these things run. I should say that especially anxiety disorders are highly genetic. There's almost always a family history of this. Also, premorbid coping style, that's what I was talking about before. Are you flexible in how you cope with things? Comorbid disorders, we know from a whole lot of pre-existing literature that especially around mood symptoms, but also anxiety symptoms, you get an additive effect. So somebody who has diabetes has less of a risk of having a mood disorder than somebody who has diabetes and COPD and cancer, and it just goes up the list. So as soon as you've got somebody who's comorbid with one or two other medical conditions, you've already got someone who's got more on their plate and more risk. This is one of the ones I find the most interesting. There's a lot of evidence. This is a very reproducible result. Having a belief system that allows you to try to form a map of understanding of the world around you. Doesn't have to be religious, doesn't have to be spiritual, could be philosophical, but having some kind of code that helps you sort of find your way through the world, something that's greater than yourself, is a very protective factor for, in general, mental illness, not just mood and anxiety and distress. And it's the same in the cancer population. I find this interesting. In terms of cancer factors, Marlene already hinted there's some cancer sites, some kinds of tumors that have a much higher risk. There's probably physiologic reasons for that, as well as associated symptom reasons. So lung cancer, often diagnosed a little later. Comes with lots of social stigma, which we'll hint at, but there may actually be physiologic links. Some of the small cell cancers in particular have been strongly associated with some neuropsychiatric disorder, so there's a much more physiologic link there. Treatment-related effects, of course, chemo, the type of chemo and radiation they receive, the associated symptoms, the disease-related effects. So is it a kind of cancer that's going to cause them a lot of pain, a lot of nausea, a lot of obstruction? All of those things increase the risk. And prognosis, especially at time of diagnosis. So this probably explains why some things like lung and pancreas carry a higher risk. Unfortunately, those are illnesses we tend to catch late, and often people are facing end of life at the same time that they're getting diagnosis. Not a lot of process time, right? You want to talk about flexibility of coping and adaptation? That's a big one. In terms of environmental factors, one of the biggest things is social isolation. And I use this is like one of my very first questions when I'm meeting a person. I want to know what their network is. Who do they go to, and how does that all work? If they have a very impoverished or limited network, one or two extremely close people that they pin everything on in terms of support, that is a very risky situation for that person. Marital status, for the most part, being married is protective, or being in a long-standing relationship is protective. I can never resist mentioning there was one very small, not reproduced study in northern Italy with elderly men with prostate cancer, where marital status being single was actually better than married. Let you speculate on that. I love that study. I have to emphasize it. It was not reproduced, but I love it. I don't know why I do, but it's so cool. Socioeconomic status. So again, not surprising, right? Lower socioeconomic status, much more burden of disease in general, in life, in society, especially in our society. Financial stressors. This is another interesting one. Not necessarily financial hardship. Some of these people are extremely wealthy, but they have a lot of concern about financial stressors, especially as related to how the disease might change their financial status. Huge risk for psychiatric morbidity. And then cultural factors, and especially the person who's right in the middle of acculturation. So not the guy who showed up 20-odd years ago and has found their way, or the person who literally just arrived and really hasn't even gotten to that yet. The person who's been here for a year or so and is just trying to break into the system, just trying to figure out how to live in this weird world, those are the folks that are at very high risk. So what do depression symptoms tend to look like in cancer patients? As Marlene has suggested, many, many people will have depressive symptoms at some point in their trajectory through the treatment and eventually survivorship journey. You definitely have higher rates in cancer patients than in other kinds of medical illness, which is quite interesting. What's interesting is that is generally true no matter what kind of cancer you have. Rates vary significantly, partly I think just because we screen for it differently, but it's a consistent finding. So they are in a higher risk group. And the higher rates of depression, as I said, tend to be associated with psychosocial factors, end of life, especially if diagnosis and end of life are very close, associated symptom factors like pain, fatigue, and nausea, sometimes the type of tumor, like I said, and then patient factors, which we talked about there. So that's kind of what it looks like. And the way that I tend to think and talk about depression and cancer is across a trajectory. So most people, here's where I wander, tell me if in your way, most people end up being here, more in the non-pathological range, right? And you probably can, off the top of your head, think about a lot of your patients having met criteria for this at some point. So these are transient symptoms. They don't really impact functioning. They tend to be, they wake up, it's rough, they don't feel so good, maybe they're nauseous, their mood goes down, it kind of tanks, and around noon they get a phone call from a friend, they go out for tea, things feel better. By the afternoon, they're better. That kind of fluctuation is quite normal and appropriate and adaptive. The middle group are the ones that we end up seeing quite a lot of in the supportive care offices and who will also probably also be at your doors. These are folks who have adjustment disorder symptoms, and we'll talk about that. An adjustment disorder is essentially a lot of symptoms like in a major depressive episode, but they don't quite meet criteria, either because they haven't been around long enough or they're really closely associated with a stressor. So let's say it's nausea. their mood symptoms fluctuate depending on what their nausea is doing that day, rather than being separate from that. And then at the very far end, we have the ones who would need to see someone like me. And fortunately, these are relatively rare, but they are the ones that are the most important to capture, because these folks really have a lot of impact on function and often have a really hard time engaging and staying engaged in their treatment. And they're the ones who meet criteria for a depressive episode. So probably everyone at some point has seen the DSM4 criteria, whether it be in a textbook somewhere, for depression. Essentially, the way for us to think about it, I think those of us who work in cancer, is there's a group of psychological symptoms and a group of what we call neurovegetative symptoms. The neurovegetative symptoms, those are the ones at the bottom. Those are great when you're trying to figure out who's depressed in young, healthy adults. Not so helpful to us, right? How many of our patients have sleep changes, energy changes, appetite changes? Not so useful. The psychological symptoms end up being very, very helpful. Low mood and anhedonia alone are enough usually to help weed apart diagnosable people versus not. Anhedonia, I don't know if everyone knows what that means. The clinical definition is a person who can no longer find pleasure or relief or joy in activities or stimuli that previously were so. I had an old supervisor who described this beautifully. He called it the babushka test. So babushka, I think, means grandmother in Russian. I was trying to actually clarify if that was the case this morning. No one was sure, but I think that's what it means. But he would describe, you know, the lady that we would often see on the wards when we were training, an elderly, married or widowed woman who'd had to come into hospital for some horrible medical reason, was sort of trapped on this unpleasant medical floor, nurses coming in to do various indignities upon her person, really is just trying to pretend she's not here, seems very sad, very, very cut off from the world. And then come the grandkids to visit, and it's all gone. She brightens up, she engages, she's interested, she wants to see what they've been doing all day at school. That's the babushka test. If she passes that, she doesn't have anhedonia. If she doesn't, then we're worried that there may be something more there. Hopelessness is another really powerful one. Hopelessness with the first two is a significant risk factor for suicidal ideation and completed suicide. So it's one of the ones we pay attention to for sure. Worthlessness, guilt, and suicidal ideation are the next three. Suicidal ideation isn't always there, and we're going to talk about it separately. You definitely don't need it to make the diagnosis for depression. And then adjustment disorders is, you can have all or any of these, usually fluctuating, and very much associated with a stressor. And it doesn't have to be one stressor, it can be 2 or 3 stressors. And when the stressors are really intense, it can be a very fine line to try to make the difference between these two. In terms of trying to predict who's going to fall where, again, with adjustment, usually what you find is with the similar stressors, the guy who falls on the adjustment side almost always has a much better supported network and usually has a better, more flexible coping style. The ones who have other risk factors, such as a personal or family history of a mood disorder, being female, there's something about being female that puts us at risk, especially for mood disorders. And certain kinds of cancers, like Marlene said, especially lung, head and neck, those are very high risk. And then associated symptoms, nausea, fatigue, pain, that kind of stuff. So in terms of treatment, this is kind of more what I end up doing a lot, but I am always happy to consult. The way we treat with medications is primarily with antidepressants. And the antidepressants that are first line right now are SSRIs, so selective serotonin reuptake inhibitors. So they're the ones that you hear, they have the most ad play on TV, Paxil, Zoloft, Celexa, Cipralex, those sorts of things. And they are first line except in patients on tamoxifen. So tamoxifen, so this is a commonly used estrogen receptor blocker in breast cancer patients and a few other populations as well. Tamoxifen actually goes through the same pathway of metabolism as a lot of these antidepressants. These antidepressants can lower the therapeutic level of tamoxifen, and there have been studies suggesting that women on these antidepressants and tamoxifen actually had worse mortality. So as a result, we don't use SSRIs if we can at all avoid it, with the exception maybe of 1 or 2 that don't go through that pathway so much. But first line is Effexor, venlafaxine with them. Venlafaxine is a good antidepressant. It belongs to a slightly different family. It has more side effects. So it's second line for everybody else unless you're on tamoxifen. Remeron, mirtazapine, is one. I know you had a lecture on nutrition. The nice thing about mirtazapine is it actually has a lot of what we call histaminic effect. So it helps a little bit with appetite stimulation, although it's less clear whether it does that in cancer patients. It also has a little bit of anti-nausea effect. So that's actually sometimes nice for our patients, and it's a little sedating. Sometimes that goes wrong. I recently had a patient who gained a little over 30 pounds in not quite 2 months. That was not on anyone's agenda, so that it can go a little wrong, but for the most part, it's actually pretty good in our population. And then the last is the tricyclic antidepressants. These are old school. They're really good, powerful antidepressants that are a little scary, and I don't recommend using them primarily as antidepressants because they have so many side effects. They are very what we call anticholinergic, so people get lightheaded, dizzy, have bladder retention, all sorts of unpleasant things. But they are very useful for certain kinds of pain, neuropathic pain. So they often end up being used by the neurologists who are helping with pain disorders rather than for depression. And they are used at lower doses for that. So that's medications, but that's actually a really small part of treating depression. Most of how we treat depression is actually with behavioral interventions, and specifically certain kinds of what we call psychotherapy. And some of these definitely you need some particular training and expertise. Cognitive behavioral therapy is probably the one with the most evidence in medically ill people, including cancer patients. This is a kind of brief interventional psychotherapy that can be tailored for certain populations. The others are equally effective. Supportive expressive therapy has been found to be very useful in cancer patients. And this is the kind of therapy that's most often used by MSWs, for example, in a setting, in a medical setting. It's the one that most will practice in. Relaxation therapy on its own is extremely useful. And this is something that you don't have to be that sophisticated to learn a few relaxation techniques and pass them on to your patients. A lot of them are even available on the internet, some how-tos about how to learn progressive muscle relaxation, how to learn different kinds of breathing techniques to kind of slow your heart rate down, sort of consciously, relax your muscles consciously. These are incredibly useful skills to learn for yourself, but also to pass on to your patients. It ends up sometimes being the best intervention you can give them, certainly better than a drug that I could give them. And finally, psychoeducation. People don't think of this, and I guess it's not formally a kind of psychotherapy, but it is a psychotherapeutic intervention, and it is hugely effective. And that's one of my take-home messages today. We've talked a lot about how common mood, and we're going to talk about anxiety, symptoms, even if not disorders, symptoms are in our patients. What we forget is they don't know that. And they have just been given this horrible diagnosis, and now they think they're kind of going crazy. They've never had these thoughts before. They've never had these feelings before. And normalizing that for them through psychoeducation can be some of the most powerful things we do for them. I love the roller coaster. I stole this slide from Marlene. So we're going to talk about anxiety symptoms now. As Marlene hinted, this is very common in our cancer population, and they tend to happen around crisis points. Just as she said, right? It's usually when something new and scary is being thrown at these folks kind of out of the blue. They can sometimes develop into anxiety disorders like panic disorders and phobias like claustrophobia and agoraphobia. That's pretty rare though. Usually they just pop up and then settle back down again. Body image anxiety is of course also pretty prevalent, especially in some populations more than others, but rarely does it, again, meet criteria for something that I would have to treat. These symptoms usually come, get dealt with, and then settle back down again. So that's good news to pass along. What we do see, and can be really problematic in terms of providing care, is the old classical conditioning. Anybody know Pavlovian conditioning, Pavlov's dogs, right? So this is the mammalian brain is really good at this, at pairing really bad, unpleasant experience with time and place and marrying those together forever. right? So someone who constantly starts feeling nauseous as soon as the LRCP pops up on the horizon, as the bus turns the corner, they start to feel it. That's an example of classical conditioning. And it's one of the places where we can intervene very early and completely change a person's course of illness. In terms of other things that can go wrong with anxiety, medical and physiologic triggers are a big one. A lot of our patients, especially when they're receiving chemo, will need things that tend to trigger anxiety symptoms in the brain. Steroids are one of the big offenders there. They need them, but I don't know if anyone in the room has ever had to have a steroid, an oral steroid. It makes you a little loopy sometimes, and you can feel very anxious, very revved up. And if you're already primed for that because you have a premorbid anxiety disorder, it can really ramp it up. One of the populations this is described in is post-traumatic stress disorder patients. It's best described in the breast cancer population. Women who had no symptoms of PTSD, did have some early trauma way back when, but it was all quiet, and then they get diagnosed with cancer, and it's usually that first exposure to something like a steroid and the PTSD symptoms pop up. So that's not an unusual circumstance. As I said, anxiety symptoms are notorious for messing, unfortunately, with treatment in a variety of ways, and they can really blur the line between physiologic and psychologically triggered symptoms. So one of the hardest things about anxiety is how physical it is, right? So everyone's had that experience of the patient who's in front of you, they're tachypnic, they're dyspneic, they don't look good, they're shaky, sweaty, pale. They also feel anxious. Are they having panic symptoms, or are they having a pulmonary embolus, or are they having a reaction to their chemo? It can get very, very messy. I had a nice video which we couldn't make work, but imagine that there's a woman having a panic attack on the other side. Essentially, I wanted to give you a rough version of what a panic attack looks like, because this is often one of the things that frontline staff see. It's one of the psychiatric symptoms that's most commonly described and very, very unpleasant and scary for the patient as well as you when it happens, especially if you don't know what it is, right? Again, it's very helpful, the psychoed piece. One of the most important things about a panic attack is if you can identify it and tell the patient, this is good, this is okay. No one dies from a panic attack. We know what to do about this. Let's get you calm. Let's get you comfortable. Why don't you sit here? And you'll survive this. It'll be fine. Because it does feel that way to the patient. It feels quite terrifying. These are the symptoms that are commonly described. So it's an intense, sudden wave of anxiety, overwhelming. They can't think or do anything else but feel this anxiety. A sense of impending doom often attached to it. And then some physical symptoms. And it can be a little bit of a mishmash of symptoms. Sometimes their heart rate goes up, they feel sweaty, they feel like they're going to pass out, they're nauseous, choking, palpitations, a wide variety of things. Sometimes they have what we call dissociative symptoms. So this can feel really weird to them, and they may not want to tell you because they might think, you might think that they're a little off. Feeling like they're outside of their body, depersonalization. Feeling like what's going on around them isn't real. They'll talk about it feeling like they're watching a TV show or something. Derealization. Those are some of the common dissociative symptoms. They usually last minutes, maximum 40, usually way less than that. And if you think about it, this is a very expensive thing to do for your body, right? This is your fight or flight instinct kicking in. It involves your adrenal glands pumping tremendous amount of catecholamines into your body. It can't do that for too long. So that usually is the cap, right? And then the person is left incredibly exhausted. So if you know this, and you know what's happening in front of your patient, you can tell, it's okay, just, we're gonna get you through this, it's gonna be over soon, and then you'll be tired and we'll be fine. And that oftentimes is enough to break this cycle. That being said, some of the commonly described anxiety disorders are generalized anxiety, panic disorder, and PTSD, and this is in the cancer population. So generalized anxiety, this is probably the commonest anxiety disorder, full stop. Most of the time when I give this lecture to the medical students, I say that there's a lot of literature supporting that if I did a canvas of your class, somewhere between 60 to 30% of you would meet criteria for this disorder, maybe higher. So it is a very common disorder, especially in some high-functioning, high-achieving, anxious, neurotic populations that I'll let you speculate on. Yeah, exactly. Chronic ruminative anxiety. And what I mean by ruminative is that kind of circling anxiety that's really purposeless. So the classic example is you are in the grocery store and you have a little bit of an altercation with the person behind you in line about who's next. And then you spend the rest of the day thinking about what you could have done differently about that altercation. And you're lying in bed wondering, how could I have made that not happen? And did I do the right thing? And what is that person thinking of me right now? That is ruminative anxiety, and it can be very, very toxic. And it's usually a lifelong disorder that's kind of subclinical. It's usually just sort of, you're a little anxious, you're a little tightly wound, maybe you're a little perfectionistic, but it's not a big deal. If anything, it helps you in your chosen career. And then it becomes a problem at a crisis point when you're losing control, i.e. being diagnosed with a cancer. It doesn't matter how hard you try, how perfectionistic you are, you're kind of along for the ride. And this is often this is the commonest presentation of anxiety I see. Panic disorder is much less common. Panic attacks, common, all over the place. Panic disorder, much more rare. A panic disorder is frequent, unexpected, untriggered panic attacks, at least 2 a week. Realistically, it's usually more like 2 a day. And it's associated with a real terror of having more panic. So they actually will change their behavior. They will stop doing things that they think might bring the panic on. So this is how things like agoraphobia develop. Last time I got in the car and drove to the mall, I had a panic attack, so I'm never doing that again. That would be the kind of sort of behavior that we would see. And it's usually episodic, so it's usually triggered by something like a cancer diagnosis or recurrence or something like that. Post-traumatic stress disorder is actually quite rare. It sometimes gets a little overdiagnosed in some populations more than others. Essentially what we're looking for here is some really traumatic life or body integrity threatening event, usually in earlier life. And it's usually more than one episode. It doesn't have to be, but it's usually sustained trauma. Like, for example, someone being abused systematically for, several years. And then things are quiet for a while, no symptoms, and then they get a re-traumatization, for example, diagnosis of cancer, and then these symptoms emerge. That's post-traumatic stress disorder. And the 3 big symptoms are re-experience, hypervigilance, and avoidance. So re-experiences, immersive re-experiences, flashbacks and nightmares, or really vivid memories the person gets kind of lost in. Hypervigilance, feeling constantly like they need to be on their guard. Every little sound startles them. They can't really sleep because they're constantly sort of aware of every little crack in the house. And avoidance, so a pattern of trying to avoid anything that might trigger the first 2 symptoms. So these are very intense and bothersome symptoms. What often gets misdiagnosed is somebody has a really bad experience, let's say, in the radiation suite. And then they have nightmares and flashbacks about that over the next few days to a week. That's normal. That's okay. That's sort of an acute stress reaction to something bad that happened, and your brain will probably settle that and be all right. This is a little bit more different. So how does anxiety usually get treated in cancer patients? Like I said, usually this is time-limited and fairly predictable, so we tend to focus more on symptom-targeted treatment. You have a panic attack every time that you're due for your radiation treatment. Let's do something about that, rather than putting you on something systematically, if we can avoid it. A few do develop an anxiety disorder of some sort, or they had an anxiety disorder and it got worse after they were diagnosed. And this is where we start talking about systematic interventions. So something that they're going to have for months, maybe even years, even after they're done their treatment. Psychotherapy is the most powerful intervention, especially for things like generalized anxiety disorder, more so than medications, some studies would suggest. And CBT is at the top of the list, cognitive behavior therapy. And if anybody has an interest in learning more about that, come and talk to me at the end and give me your email and I can send you a few things about it. But it is probably one of the most studied kind of psychotherapy interventions right now. Relaxation techniques, we already talked about that. And then if you really do have someone with something like complex PTSD, then you're thinking about sending them to a very specialized kind of psychotherapy called a trauma program. And those, just to give you an idea, it's about 2 years of intensive psychotherapy. So it's a pretty detailed treatment. Medications, when we do need medications, and we sometimes do, If we're thinking this, we know exactly when the anxiety happens. I can predict when it's going to happen. I know when it is. We might use something like benzodiazepines to try to smooth that out and just give it to them before they get into the MRI, something like that. Antidepressants like SSRIs are the treatment for more systematic treatment. If somebody, let's say, does have a generalized anxiety disorder and is not coping well, we would put them on an SSRI. Effexor, again, is the backup plan for people on tamoxifen in particular. And then, this is a little off the map, but let's say, for example, lung cancer patients, they often have panic symptoms, but they can't take benzodiazepines. Benzodiazepines suppress your respiratory drive. So then we have to get a little exotic, and sometimes we put them on things like antipsychotics, specific kinds of antipsychotics that we know are anxiolytic that help with anxiety. Very briefly, we're going to talk about two related things that just crop up and really interfere a lot of time, not just in oncologic treatment, but in treatment of mood or anxiety disorders in a cancer patient. And I'm sure I don't have to talk to anyone in the room too much about the impact of substance abuse in our population, right? This is huge. And it's one of the things we, I think, do least well. Alcohol, tobacco, and marijuana are the big offenders here. That's what many of our patients will have. And there's huge barriers to treatment as soon as they walk in the door. The biggest is poor coping skills. I mean, as one of my friends, she put it really eloquently, if you need a drug to cope, you don't have good coping skills. Like, it's kind of pathognomonic, right? So already we've got somebody who's struggling to adapt to rapidly changing stressors. They often have little support, especially if they have fairly significant substance use. You may have physiologic dependence, so somebody who's at risk of withdrawal, and the oncologist is telling them you can't drink. That's problematic, you know, we have to help them with that. Socioeconomic barriers are huge, again, especially for somebody who's really had this problem for a while and had all the downward drift usually associated with it. The stigma piece, and then this for me is one of the, I feel like this is a constant kick in the teeth for patients. Very few treatment programs are designed for cancer patients. And often they are barred from some treatment programs because they are on drugs, you know, that we're giving them. So it's hugely problematic. There's not a lot of resources for them. So we end up having to sort of make up something for them within our institution. And then the potential exposure to new drugs is huge as well, right? So you have someone who's maybe been clean from heroin for 10 years, and now they're going to have a dilaudid pump. You can just imagine how things can go wrong. So all of these things end up complicating care. Suicide is the other thing everybody gets quite anxious about, but the reality is suicide's a really rare event. You know, as much as we really worry about it, especially in psychiatry, it's big on our agenda. Overall, it's a rare event, especially in our society. However, it is increased in cancer population compared to the general population. What's more common is actually the wish for hastened death. And you guys, I'm sure everyone's heard this in some variation. I would be okay if I just didn't wake up tomorrow, if I just, you know, had a stroke or something at night. That'd be fine, I'd be okay with that. In fact, I would prefer that than having to go through what I'm going through right now. It's fairly common, it's a sign of distress, we need to pay attention to it, but it does not translate into risk of self-harm. In fact, those two don't seem as connected as we would imagine. Similarly, the escape hatch sort of thinking, if I end up in a wheelchair, that's it, I'm done. Or if I end up needing a ventilator, that's it, I'm done. You know, these sorts of kind of lines in the sand that patients draw usually don't translate into self-harm. It's actually usually a fairly adaptive coping style, and it's interesting, they often get to that point and manage better than they think they will, right? So it seems to be more a way of maintaining control. It's also really hard sometimes to differentiate end-of-life planning versus suicidal ideation, especially in someone who just got diagnosed and they're very far along, right? Someone refusing what seems to us a reasonable intervention in terms of, let's say, palliative radiation, it can feel like it's suicidal behavior, and it may actually be influenced more by decisions around quality of life. So it can be tricky to figure this out. There is a high-risk group, though. Get worried if your patient comes in and is talking very specifically about plans, intent, and means. I would do it this way. I would do it with these drugs I have at home, and I know exactly where they are, and I know when my husband's not likely to be around. That's scary. So that's a different level of risk. Or if there's a strong history of either self-harm or a family history of completed suicide, that's the other big risk factor. Or if there's a comorbid substance use disorder, because that makes people impulsive and more likely to do things without thinking. Overall, who's at risk? Again, these tend not to be surprises. Male, Caucasian. So it's interesting, right? Females, high risk for mood disorders. Male, high risk for suicide. Males, Caucasian, unmarried, older age, especially in men, and advanced diagnosis at time, or advanced disease at time of diagnosis. So again, that prognosis grim at the time you're hearing the news for the first time is a very dangerous point. Anatomic site matters as well. So again, as Marlene suggested, lung is particularly high risk. Stomach, head and neck, and laryngeal. So kind of same trend, right? The same guys that are high risk for mood disorders, high risk for suicide. This is the scary one, as far as I'm concerned, the time of diagnosis. So if you look at when a person is diagnosed with cancer and when they're likely to suicide, if they're going to suicide, highest risk is in the first 3 months. And in that, really, it's the first month that over 30% of completed suicides will happen. The first year is higher risk than the rest, and then after that it starts to kind of go back to sort of background noise of general population rates. You can really see that in this here. Frequency of suicides, months since diagnosis. Look at the first month. Add up the first 3 months. How many people make it to a cancer clinic appointment in the first month since diagnosis? This is freaky, right? And when I give presentations like this to our colleagues in primary care, this is one of my big points. Because when you're giving someone this diagnosis, you may be the only person they see in that window of risk, and that first month is very problematic. This is, by the way, UK data that's been replicated in 2 American sites, so it's pretty robust. The other scary part is that these rates in that first year haven't changed. So if you think about all the things that have happened in terms of treatment options and symptom management and options for people who are being diagnosed at poor prognosis, between 1973 and 2005, a lot has happened. Rates of suicide about the same. So it's very clearly something that is more complicated than just what the diagnosis might mean in terms of treatment and symptom management. And I've talked a lot about, what psychiatric disorders look like. She's talked about distress, and now we're going to talk a little bit about what you actually do to try to differentiate these populations.
So certainly very frightening that suicide risk is so high, so early on, and as Carla said, in particular before any formal supports are in place. But what do we do? How do we know who needs what? How do we know when they need it? Do we throw the book at everyone? Do we give them every resource? I want you to think about that. All patients don't need everything. I'm getting a little controversial here, but someone named Marg Fitch, who is an RN, PhD, came up with this model to consider what patients need over time. So at the very top, she's proposing that all patients need good distress screening, relevant information, basic communication, basic emotional support, and symptom management. And in fact, she suggests that about 20% of patients, that's all they're going to need. Many need additional information, education, and encouragement to seek help. That's about the 30% range. And the bottom 2 is where really supportive care sort of sits. Some patients require specialized professional intervention. That's between 35 and 40. And for complex care, it's about 10 to 15. So that is really where Dr. Garcia sits. The point is that more isn't always better, and I'm going to suggest that especially when you've got a moderately or severely anxious patient, we can actually contribute a little bit to some increased anxiety. This is just another way to think about levels of intervention. So low level, everybody should get universal care, and then it goes up to the most complex care. I have apologized in advance to Dr. Garcia because I do use this analogy about thinking of distress and treatment of distress as being similar to a Tylenol versus a long-acting narcotic. So you can imagine which one she is. And if you're thinking about that, I want to throw it out there that you don't want to overdose the patient, okay? Conversely, if someone needs complex care, you don't want to just give them a Tylenol. You want them to be at a therapeutic dose, okay? I know it's a different analogy, but I hope the point is coming through. So if we believe that about 35 to 40% of patients are going to need specialized professional intervention, guess what? Only about a third of them are going to accept it. There's that roller coaster again. Just wanting one more time to highlight that there are peaks along the way. There are periods where patients are more vulnerable than others. In your packages, and I'm not going to get into details because I think we're pressing time a little bit here, there is an algorithm for anxiety and one for depression. I just wanted to point out a couple things about that. This was developed by Cancer Care Ontario. It's on the website. It's actually a useful tool, so if you have time, check it out. Basically, the algorithm is to guide a conversation or your assessment within the clinical encounter. So it highlights what should be addressed, allows you to prioritize that a little bit, and it helps with decisions about what interventions you can provide and what referrals you need to make. So again, this idea that you're not going to overdose the patient and you're going to make sure that the patient is getting sort of a therapeutic dose of whatever they're getting from a supportive care point of view. They use a stoplight analogy, which is obvious, that green is go, yellow is wait a minute, there could be a problem brewing here, you may need to do something, and red is obviously don't collect $200, you need to actually do something about this, okay? Over the last 10 years, lots of emphasis on identifying distress, and now within cancer programs, it really is moving towards symptom management, not just of distress, and most of the cancer centers in Ontario have got these guides now for other symptoms, including nausea, dyspnea, and it's good to see that anxiety and depression are also on those. Not simply enough to identify it. We don't want to throw the book at all of the patients. There needs to be a little bit more of a systematic approach in terms of treating distress, anxiety, and depression, just so you don't walk away depressed. You need to know that things do get better for people. In terms of overall adjustment, most are doing well within the initial 1 to 2 years, which seems like an incredibly long time post-treatment. There is a subset of survivors, though, that really require ongoing psychiatric treatment, and you've talked about that. There's this other group that has this subsyndromal level of distress that they still might need more than just the Tylenol. And we have to think about how we're going to serve these patients in the future as more patients survive, as there's more survivors, and as we think about cancer really as being more of a chronic disease. I like this picture, and if you're a nurse, you're a first responder, if you're a nurse and others working in oncology, I'm going to suggest that when you're dealing with life-threatening emergencies that require one part of your brain, the cognitive part, to sort out these tasks, and while simultaneously showing some empathy and emotional support for the patient, I think it's quite a daunting task. So there's first responders, and you guys in oncology, you're kind of sustained responders as well. There was a nice little article, I'm sorry I didn't have a chance to get the reference on this, but I can make it available to you, that talks about nurses and social workers, all of us that work in oncology as being these sustained responders and some of the challenges. So we're going to plant a little seed for something else, and I'll let you wrap up.
That's actually one of the things we didn't have time to include in this talk, but we really would like your honest feedback, whether you think it would be helpful, was maybe at some later date, if we were able to do this again, something more around some of the healthcare provider related issues around distress, right? Because burnout is huge. And there's a lot of ways that it happens, some of which are predictable and therefore preventable, and some of which are less so. But it really warrants its own talk. We were going to somehow squeeze it in here, and it just seemed a little insane. So we pose it as a question to you guys. If it seems like something you want, we can definitely think of doing that, because there is, as Marlene hinted, some really good literature out there that I think would actually be helpful to all of us. So take-home points. Distress is inevitable. It's inevitable in life, but it's especially inevitable in cancer, right? And that's okay. That's the nature of what we do. But specific psychiatric disorders, although they're more common in cancer patients versus some other populations, they're still relatively rare, and that's good news. Most patients with distress, even really significant distress, they're going to be back at their baseline without a ton of help from me within 1 to 2 years. They're going to be okay, most of them. That being said, though, we really need to work at getting better at identifying the high-risk patients, because those are the ones who really pay the price. Morbidity and mortality is dramatically affected when there is an untreated mood or anxiety disorder. These are the ones that don't complete treatment and pay that price, right? So those are the tragedies that we try so hard to avoid. My biggest take-home point, which I think I hinted at earlier, is the psychoeducation piece. This is sometimes the biggest part of the intervention we can give people, right? And it's important to remember part of that is problem solving around immediate issues, being that assistant to the patient at that moment, of helping them figure out how they're going to cope and adapt to this new problem that life has thrown at them, that nothing they've ever experienced in their life has prepared them for. But also the information sharing and the normalizing. It is okay to feel the way you are feeling right now. We can take a look at that in more detail and make sure it's not interfering with your ability to function. But this doesn't necessarily imply that something else is broken in you, which is one of the things that our patients feel the most, right, after a diagnosis. So I think those were the main things we wanted you to walk out of here with. I know it's been a really long day, and I thank you for your patience.